Good afternoon. If you're not already in a seat, let me encourage you to find one. We have a full house. That's a good problem to have if you're in the events business, so I'm not going to apologize for it, but I hope that everyone is not inconvenienced by the size of the room. And if you have not yet grabbed a lunch, you still have a minute or two before we get started with the actual program to do so. I want to welcome you to the Baker Institute here at Rice. I'm Evan Smith, the editor-in-chief of the Texas Tribune. We are always happy to come to Houston to do events. We're always happy to be on a college campus in Houston. We're especially happy to come to Rice University and to the Baker Institute to do events here. And I want to thank the ambassador in his absence. I want to thank Ryan Kirksey. I want to thank the staff of the Baker Institute. I especially want to thank Vivian Ho, without whom we would not be here. Please acknowledge the Baker Institute folks and the Rice University folks for their generosity in welcoming us onto their campus again. You may know that the Texas Tribune is a nonprofit digital news organization. We're nonpartisan, we're community supported, and we do news, we do data, and we do events. We cover public policy and politics in the state of Texas, and since early 2010, we have been doing events around the state like this one, built around either issues or individuals in public life to discuss the priorities of the state of Texas, all serious topics. And the conversation today is part of a series of conversations on healthcare that we are fortunate to do with the support of Blue Cross Blue Shield of Texas. We did one back in August on the state of Texas and where we are with healthcare reform. In a couple of weeks, we're going to do one in the city of San Antonio on the transformation of medical education in the state of Texas. And today we're very pleased to present this conversation about changing population and changing healthcare. The Blue Cross Blue Shield of Texas folks have been generous supporters of the Tribune for several years, of our events particularly. Please acknowledge their support and give them a hand. Donors and supporters on the corporate end, like Blue Cross of the Tribune, play no role in the content or the panelists or the questions at an event like this, but they support the mission of the Tribune, which is to inform and to engage Texans on the big issues that matter. We are a free public media organization. The content that we produce every day at texastribune.org, and almost all of our events are free to attend, but like public radio or public television in Houston and elsewhere, if you like what you get, we ask that you consider giving us a few bucks. And I'll just mention that we are a member organization, and if you go to texastribune.org/join, you can become a member of the Texas Tribune. We're going to ask that you silence your phones. If you are tweeting this event, which I know some of you are apt to do, the hashtag is TribLive, but please turn your phone completely off, not to vibrate, but completely silent. If not, if you're not going to tweet this event, just turn your phone completely off. We're going to have about 35 to 40 minutes of conversation with our panelists. The balance of our time will be questions from the audience. We're live streaming this event at texastribune.org. For people who couldn't be here, we'll also post the video almost immediately when the event's concluded. So if you'd like to see what you saw in person, you can go back to the website after this event or tell people to come and check it out. Beyond that, I'm going to introduce our panelists. I'll ask them to go ahead and take the stage now while I introduce them, and we'll get our conversation started. We have 5 distinguished panelists who are joining us today for this conversation about changing population and changing healthcare. I'm going to introduce them alphabetically as they'll be seated next to me. Vivian Ho is the James A. Baker III Institute Chair in Health Economics at Rice University, Director of its Health Policy Forum, and a professor in its Department of Economics. She served on the Board of Scientific Counselors for the National Center for Health Statistics and is a founding board member of the American Society of Health Economics. Elena Marks is president and CEO of the Episcopal Health Foundation, in that capacity overseeing a $1 billion nonprofit engaged in community health transformation in Texas. She's also a non-resident fellow in health policy here at the Baker Institute. Previously, she served as director of health and environmental policy for the city of Houston. Steve Murdoch is the Alan and Gladys Klein Chair in Sociology here at Rice, where he's also founding director of the Hobby Center for the Study of Texas. He's a former Texas state demographer and a former director of the U.S. Census Bureau, tapped for those posts by Governor Rick Perry and President George W. Bush, respectively. Orlando Sanchez was first elected Harris County Treasurer in 2006, the first immigrant to be chosen countywide by the voters for a non-judicial office. He's running for re-election as the Republican Party's nominee this year. He faces a Democrat, David Rosen, on the November ballot. He formerly served 3 terms on the Houston City Council and has twice run for mayor. Finally, Sylvester Turner, Democrat of Houston, has represented District 139 in the Texas House since 1989. He too is running for re-election this year, but he had no opponent in the primary and has none in the general, so he's already won. Congratulations, Representative. They say no elections are over until they're over. His is over, so we just acknowledge that. In the 83rd legislative session, he served as vice chairman of the Appropriations Committee and a member of the State Affairs Committee. He too has run twice for Houston mayor, once against Treasurer Sanchez. Please welcome the 5 distinguished panelists. It's tradition at an event about demographic change in the state of Texas, and has been for many years, to defer to Mr. Murdoch, who is, after all, the prophet. He's the one who can look into the future and with a reasonable amount of certainty tell us what the future looks like. And so I'm going to ask Mr. Murdoch to spend a minute or 2 or 3 setting the table for our conversation today, telling us what the numbers look like and what we can expect from the standpoint of population in the state of Texas as a backdrop to the conversation we're about to have. Mr. Murdoch.
Okay, thank you, Evan. I'd like to say that we are sitting in the fastest growing state and in the fastest growing city, and fastest growing metropolitan area in the United States. Texas has grown rapidly for decades now. We were the most rapidly growing state last decade. We're leading this decade with an increase of 1.3 million people from April 1st of 2010 to July 1st of 2013, the most recent data we have. This MSA, in that same period of time, has increased about 385,000 people during that period of time from 2010 to 2013. Dallas metropolitan area is a little bit behind us. And behind that is New York City and its metropolitan area. What's, I think, really impressive to understand is with a little over 6 million in each of our metropolitan areas, that is in Houston and in Dallas, we're growing more than the New York MSA with a little over 19 million people. So in absolute numbers, our growth is phenomenal, let alone in percentage terms. We are diversifying very rapidly. We and others project that Texas, which this last decade from 2000 to 2010 became less than half non-Hispanic white, will by 2050 be about 21% non-Hispanic white, about 55% Hispanic, about 10% African American, and with the remainder being Asian and people of 2 or more races, etc. So we're growing, we're diversifying very quickly. That is true for the state as a whole. It's true for Houston as a city. It's true for Houston as a metropolitan area. And it's true virtually for all of our large metropolitan centers. So we are a state whose people represent all parts of the world, and a state which therefore has interests in a variety of commercial and public issues as we go forward.
Mr. Murdoch, we think about demography, and maybe I could ask the audio people. I seem to have double microphones here. Maybe this microphone could be turned off if somebody's listening to this, the podium mic. Mr. Murdoch, we hear about demography, we think about the change in the racial and ethnic makeup of our population, but the reality is demography means more than just that. Isn't it also true that in 2040 we're going to see the population 65 and older in the state will actually have significantly increased as a percentage of our population, which could have implications for the topic we're here to talk about today?
Right. We're about 12 to 13% elderly now. We'll be about 22% elderly by 2050. And entailed in this change in our composition is the fact that if we don't change the socioeconomics that go with some of our demographic characteristics, for example, we know that African Americans and Hispanics in Texas as a whole make considerably less than is true for non-Hispanic whites. If we don't change the economics that go with our demographics, we will, as a state, be a poorer and less competitive state in the future than we are today. I think one of the things, for example, that people are finding surprising, but which I don't find surprising, nor I think most demographers, is that if you look at some of the economic data that's come out just recently, people look at it and they say, well, it's a boom time. And when you look at median or mean kinds of factors, you don't find the income raising rapidly, because it's a bipolar kind of situation. That is, part of that distribution is doing very well, and yes, they're making a lot more money.
Yep.
The other side is not doing as well, and often is finding their rents going up significantly and other costs. And that is true in not only in places like here in Dallas, but it's also true in the Midland, Odessa.
So boom times are not necessarily touching everybody.
That's correct.
Representative Turner, this is really an issue that begins at the Capitol. It's a matter of state policy. We have been engaged in a discussion about health care for many years, but it was particularly potent in the last legislative session when the opportunity to expand Medicaid and embrace key aspects of the Affordable Care Act was on the table. The legislature rejected that opportunity. So can you talk from a state policy perspective about what you hear Mr. Murdoch saying and how that makes you think about what the state is and should be doing?
Thanks, Evan. We're certainly facing Am I on?
There you go. All right, great.
There we go.
Yep.
Okay. As Steve was indicating earlier, the state is changing.
Yeah.
And with that, it is creating a tremendous strain on our healthcare system in the state of Texas, no question about that. Back in 2010, about 42% of doctors were treating Medicaid patients in the state of Texas. In 2012, that number has dropped to about a third, about 31 to 33%. It is the lowest in our history. You have a situation, for example, that the healthcare system in the state of Texas is already under tremendous strain.
Yep.
It's already under tremendous pressure. And more people are utilizing our system. Now, in the last legislative session, we had an opportunity to expand Medicaid. The legislature chose not to expand. I think that's unfortunate. In this state, we are still, percentage-wise, we are number one in terms of the number of people that are uninsured in this state.
Right.
And when you're looking at the state of Texas, it's a young population. We have 2 million, California has 2 million more kids than we do in the state of Texas, and yet and still we have more uninsured kids in Texas than in California. So there, the system is under a current strain. And if you separate and apart from ACA, separate and apart from Medicaid expansion, it's a system that we cannot sustain. There's a tremendous amount of pressure.
And the cost as a percentage of the state budget, Representative Turner, are said on healthcare to be rising now to meet and possibly exceed the amount of money we spend on public education. That would be unprecedented in the state.
That would be unprecedented, but at the same time, in the last legislative session, had the state of Texas, for example, had we invested $1 billion over the next 4 years, had we invested $52 million, we would have pulled down from the feds $4 billion over a 2-year period.
Right.
The legislature chose not to do that. We
Right.
can't continue that sort of policy. We are losing $300 million a month for the state of Texas because we chose not to expand and enter into ACA.
Right.
$300 million. And the uncompensated care in the state of Texas a year is about $5.5 billion.
Yeah.
The counties are paying about $1 billion.
And I want to hit the treasurer on that because obviously from a county standpoint, I think he could speak to the impact on Harris County. But let me come to Ms. Ho for a second and ask what the implications of what Mr. Turner said are. He said that by declining to take advantage of the money that would have come to us from the feds, the scenario that Mr. Murdoch talked about, you understand where these numbers are going. What are the implications of not making the decision that Representative Turner talked about? So by not taking the money, what are the implications for the economy of the state of Texas?
Well, first of all, there's a direct effect upon our hospitals, which are taking care of these patients as uninsured patients. And so that's an increased financial stress on the hospitals that treat not just them, but treat us as well.
Yep.
And there is literature showing that those communities with higher numbers of uninsured people actually have lower quality care for the people who are insured. So it's influencing us in terms of the insured people. We're getting less access to care, less access to specialists, fewer referrals, less patient satisfaction because we have this high rate of uninsured, which could have been sort of substantially reduced by Medicaid.
Yeah.
In terms of the wider economic implications, we all know in economics about a government multiplier effect, the effect of spending these additional dollars. They go not just in the healthcare industry, but they go throughout the entire economy. So we're we're missing out on an additional economic boom that we could take advantage of that's going on in other states. It's sort of our taxpayer dollars are paying for an economic boom in Connecticut and California, all these other states, and we're losing out on that.
Yeah. Treasurer, this is a compelling argument. A lot of people in the state think, we're leaving money on the table. You have you would think of as fairly conservative quarters, the city of Beaumont, you have the newspaper editorializing 2 weeks ago that we need to be more pragmatic about Medicaid and at least take this money that's been made available to us. If Medicaid may not be the best system in the world, but we're just losing out on these dollars that, to Ms. Ho's point, really are our tax dollars that we're letting go to other states. Are you persuaded?
Well, Evan, I look at, in my position, being elected, first of all, by everyone in the city of Houston and then everyone in Harris County. I look at my job as sort of helping manage interests. There are a lot of interests in our community. There's preservationists, and there's people wanting to save the Astrodome.
Right.
And there's people wanting infrastructure, and there's people wanting better health care. And we can do all those things. The question is, how far are we willing to go with our tax dollars? And in Harris County, as you know, our property taxes fund the Harris Health, and so we're very limited in the amount of money that we can provide that system.
Right.
And so we can do a multiplicity of things. The question is how far we can push the envelope with respect to the taxpayers willing to pony up. And so, those of us that run for public office, we listen to the public. We appreciate these forums because this is how we learn. But at the end of the day, in our representative democracy, it is the people that make those decisions.
You're just responsive to the vote.
That's right. And the state of Texas has continued to reelect the leadership that has decided not to go down the path of expanded Medicaid in the state of Texas and take advantage of the Affordable Health Care Act and the benefits it brings to the communities, and the public continues to reelect those folks.
So your sense is elections have consequences. If the people of the state of Texas wanted to go a different route, they would elect different people to high office.
I think that's what I'm getting at.
Yeah. So, but as you well know, I'm going to come Representative Turley West and then to Ms. Marks. Treasurer, you understand though that what people look to you for is not just responsive government, but also leadership. And so, to the extent that what you're responsible for is leadership, do you believe that you would like to see an expansion of Medicaid, as so many county judges in the big urban counties do? I mean, you know that all the 6 big urban counties, you have the majority of elected officials have come out for Medicaid expansion. What
are you asking me as the treasurer of Harris County?
Yes.
Yeah, I don't make public policy in Harris
but you have
County,
an opinion personally. I'd love to hear it.
Well, absolutely. I tell you, I look at the population in Harris County, and you look at every indicator, whether, as Dr. Murdoch says, the numbers are expanding in a particular ethnic group. So a lot of Latinos coming to the city of Houston and Harris County. And so when you look at public education, it's estimated that half of the students that started high school this year in HISD may not graduate. When you look at the number of people that have ability to see a primary health care physician, it doesn't exist. So yes, we need resources in the healthcare arena to address the issues, because at the end of the day, when a woman presents herself, a pregnant mom, let's say at the ER, one of only 2 level 1 trauma centers in Harris County with hypertension, and she's pregnant, we have a decision to make. We can either say, and by the way, undocumented, look, it's not life-threatening right now, and just go on, and then she perhaps would stroke out, come back to the ER, and the cost of treating that would be hundreds of thousands of dollars, not only the mom, but the child. Right. Or we could say, here's $15 hypertension medication, and you have
So did you tell me whether you favor expansion of Medicaid or not? I couldn't actually tell in that.
Look, I favor looking at the system and improving the current system that we have in the state of Texas. I think there is a possibility to save a lot of money, but it is my understanding that we can participate in the Medicaid program, and if we don't like it, we can back out of it. I don't understand why the state of Texas doesn't try it.
Representative, and then over to Ms. Marks.
Yeah, the reality is that I think of the reason why some people are not in favor of expanding Medicaid is because they have not educated themselves. They don't have the information. Whether you choose not to, if you choose not to participate, if you have private health insurance, you're going to pay more because you're going to pay for those people who are walking into your ER. When you have a large percentage of people who either with Medicaid now or don't have it, when they get sick, they are going to the ER. Who ends up paying that bill? It becomes your property tax owners. They're paying the tab. When you have hospitals that are closing down because they're under a tremendous amount of stress, who ends up having to pick up the slack? The reality is, whether you're a conservative, whether you're a Democrat, whether you're a Republican, whether you're a homeowner, you are paying for this uncompensated care.
Right.
From a fiscal point of view, it doesn't make any sense when the state can write a check for $52 million and pull down $4 billion. Those dollars were not made in D.C. Those dollars came from the people in this room.
That, to Ms. Host's point, there are tax dollars.
Right, so from a fiscal point of view, a conservative fiscal point of view, it makes good sense to take advantage of a system that allows you to bring dollars into your system. And just like was indicated earlier, by expanding Medicaid, you'll generate about 59,000 jobs that are supported by this system. So there, on every indicator, there's every reason to do it. If, for example, you decide that we don't want to do it down the road, we can opt out. But the reality is, because we did not opt in the last legislative session, you can't go back and retrieve that $4 billion. That $4 billion is gone. You can't get it back. And so for the first 3 years, the feds will pay 100%. For the remaining years after that, you end up, the feds will pay at least 90%. So with changing demographics, with 1 out of 5 African Americans needing health care, 1 out of 4 Hispanics needing health care, a changing demographic system, when people get sick, they're not staying at home, they are going to ER, they are stressing our system, and all of us, private health insurance property owners, all of us, we are paying the tax.
Are already paying for it. Now, Ms. Marks, what I'm hearing is inaction on the part of the state, despite the best efforts of some to cause some action to happen of some sort. And so what's happening is the big boulder is rolling downhill. And one of the places it's rolling to are organizations like yours. The outside groups are having to try to step in and contribute to the solution, even if the state and the public side can't. So can you talk about what the foundation's doing and its view of this issue, and particularly of the stress on the population?
Well, philanthropy cannot and should not take the place of government or of sound public policy. We don't have that kind of money, and it's frankly not our role. Our board has been very clear about we should not be doing things that are other people's responsibility. And if the state is digging a hole that's getting deeper and deeper, it's harder and harder for us to make any meaningful contribution to that. What we are really good at in philanthropy is testing out different solutions, funding pilot projects, and figuring out interesting and new ways to work. And often government adopts the solutions that philanthropy begins to fund. What we can't do, though, is make up for what government traditionally has done. If you look at the cuts in the NIA budget and look to philanthropy to fill that, it's not going to happen. We don't have that kind of money. Philanthropy in 2013 contributed about $350 billion to the economy, less than 2%. It is a drop in the bucket compared to state or local or federal government expenditures, and we cannot make it up. And if you continue digging the hole deeper and deeper for us, we are further inhibited in making a valuable contribution.
Well, expectations calibrated, but you are trying to do what you can. And as you said, pilot programs, you can fund some small scale efforts that maybe become larger scale in the hands of other people. Talk a little bit about some of the things you've done specifically.
Well, some of the things that we want to do have to do with the healthcare delivery system. How do you get people first in prevention so that they don't even need to interact with the healthcare delivery system? Once they do interact with the healthcare delivery system, how do you set up practices and clinics and infrastructure so that people are getting services at the right time, at the right place, and at the right cost? And those are systemic changes that need to take place and that are best driven through public policy. And when they're not being driven through public policy, we have the opportunity to fund organizations that believe in this kind of structure and get them to demonstrate the value.
Mr. Murdoch, you talked about the poverty question as part of the change in demographics. This is a state that has enjoyed pretty robust economic times over the last few years, weathered the recession better than most places. And we brag about the fact that we're adding 1,000 people to the state or more a day, but we also know that those people are not bringing health care with them from other states. They're just people who are added onto the existing system. What does the particular nature of change in our population tell you about where this conversation is likely to go over the next, say, 10 years?
Well, I think, one thing to understand is that, and this is true throughout Texas, this is not a thing that's only true in South Texas or only true in East Texas or West Texas, is that if you look at poverty rates for African Americans and Hispanics in Texas are 2 to 3 times as high as they are for non-Hispanic whites. Incomes are somewhere between 60 and 75%. And again, it really doesn't matter. It's true in Houston, it's true in Dallas, it's true in San Antonio, it's true in El Paso, it's true in Harlingen, etc. So we have a very pervasive set of socioeconomic characteristics that we need to address, I think, as a state if we really do want to be competitive in all ways in economic terms. And I think that, just picking what we've been talking about for the last few minutes, is that it's interesting, as you noted, that when it comes to Medicaid expansion, the judges of all of the largest counties in the state have signed on for it, and I understand there's financial reasons for that, but have done it. We're seeing business leaders now beginning to sign on and saying, we pay huge amounts of taxes, and what do you mean that they're not going to be used to address the needs of the people who work for us, particularly those that are at the bottom end. So, the thing that worries me in the long term is that people sometimes look at this and they'll say, well, but that's certain people. It's those people who are needing those services. It's not, it's not something that impacts the entire state. But as you know, in a recent book that we did, we looked at the analysis of this and find out we all pay.
Right.
The average household income from our analysis, if you look in 2010 dollars, if we don't close these gaps, socioeconomic gaps, the average household in Texas in 2050 will be making $7,700 less than it did in 2010. We'll see poverty rates go up 2 to 3%.
Yep.
If we could close these gaps through a variety of programs, including the medical programs, we could see increases, substantial increases, for example, so that our income could increase rather than decrease. We could see our poverty rates close to being at least the same as, in some cases lower than, other states that we're now not in that thing with. So that closing these socioeconomic gaps is not just something that's good for a subset of people. You can look at it in tax revenues, you can look at it in income. It is something that is good for Texas as a whole. And so, and failing to do so means that we also fail to do things that are good for all parts of Texas.
Mr. Sanchez, both Mr. Murdoch and Representative Turner have made the point that we all pay, regardless of whether the state does anything to solve this problem. We all pay. It's undeniable that at the county level, the uncompensated care costs are being passed on to everybody who pays property taxes, right? That's it.
Or has a health insurance.
Or has health insurance. So can you give us a window on, from the county's perspective, the magnitude of this problem?
It's interesting. Well, it's huge. Given the numbers that Dr. Murdoch is talking about, the number of people coming to Texas, and we have to recognize we have a large number of undocumented people coming to the state of Texas and then inevitably end up in Houston and at our public hospital system. It's interesting when I have some dialogue with some of my colleagues, it's always the immigration issue, and I always remind them, it's an immigration issue at the border, it becomes a health care issue once they're here. And so,
if not to say a public education issue or what have you, right? It becomes an issue on a number of fronts.
That's right.
Yeah.
And but since we're talking about healthcare, it becomes a healthcare issue. So the question is, the society has X number of dollars to spend on certain interests.
Right.
And And, I heard someone say the other day, well, we're not going to do anything to harm them. This was a quote, but we're not going to do anything to help them. And that's the question is the society going to look, as Dr. Murdoch says, these people, we look at them differently than we do ourselves.
Yep.
And are we going to say, look, this is a very myopic approach, because at the end of the day, this is going to be the future of the state of Texas, and it's going to be the future of our country. Are we going to provide health care for them? And health care, comprehensive health care? I'm not talking about just, premiums for the Affordable Care Act, but within the Affordable Care Act, I look at it, there's not a lot of incentive for people that are low income, let's say, or let's say somebody $30,000 a year income, $35,000 a year. I think the health care policy, if they go to the Affordable Care Act, the marketplace is $750 annually, or $1,200. But if they don't sign up, I understand they're penalized, or they pay a tax of 1% of adjusted gross income. So it's easier to pay the fine than to buy the policy. And so they say, well, we can sign up since we don't have any pre-existing condition. We'll wait till we get sick, and then we'll just buy the policy. Then, of course, they can drop it. So human nature being human nature, that's what a lot of people are going to do, in my opinion.
Ms. Marks wanted to jump in here on that, whether in response to Mr. Sanchez or to the, please.
Well, 2 parts down in what you were saying. The county over the last 2 years has cut the tax rate payable to Harris Health System, not to the taxpayer. It's just reallocated 2 cents to other county priorities. And the direct impact of that is that services have been cut or will be cut within the Harris Health System. And the impact on a foundation is community members coming to us and saying, the hospital district has made these cuts, can you pay for these services?
Yeah.
And we've had direct applications relating to cuts to outreach workers who no longer are available in the community just to enroll people in the Harris Health System program. And so we have local government piling on top of state government, on top of cuts to the federal government,
right.
And it's all rolling to us.
Yeah. Mr. Murdoch.
Yeah, just one question.
Yeah.
One thing I want to make clear is I think there's a lot of the fervor that gets set around undocumented immigrants. Undocumented immigrants, yes, they are about 1.8 or 9 million people in Texas. They probably increased 150,000 since 2010. But they are, in very few cases, are they the driving force, because their numbers are much lower than people think. If you ask people in the country, for example, and the Pew Hispanic Center says there's somewhere between 11 and 12 million in the country. If you ask in lots of surveys, people will say, oh no, there's 20 or there's 30 million in the country. And I always talk to Jeff Pacell, who from the Pew Hispanic Center, he's a demographer that was educated at the University of Texas at Austin. His family still lives in Dallas. And I say, well, how do you know? How do you know there's actually 12 or 13 million and not 20 or 30 million? And his answer, which I find fairly convincing, is he says, there's one thing you cannot hide, and that is dying. And if there's really 20 or 30 million of these people, they are the healthiest group of people who have ever walked the face of the earth, because they die like about.
You're not seeing a lot of dead bodies, are you?
So my only point
Right.
is not to say that they're not an issue, but sometimes everything we're having about uninsured is getting laid on undocumented immigrants, or et cetera, and that is really, I think, not possible with the numbers.
Let me ask Representative Turner and then Ms. Ho, the undocumented or not, the fact is the Latino population is the rocket booster of our population growth overall, and is going to be, as Mr. Murdoch said, by 2040 will be more than 50%, if not quite a bit before that, and by 2050, 55%. Representative Turner, from your perspective, what does the fact that our population change is fueled in large part by the Latino population growing mean for this conversation about health care? What does it mean in terms of what we should be thinking about?
Well, I think we need to be thinking about who's in our education system, who's going to make up our workforce,
right?
Whether or not we want a skilled, healthy labor workforce.
Yep.
And I think we want to keep them healthy. So it doesn't matter whether we're talking about Latinos, whether we're talking about African Americans, whether we're talking about Asians, whether we're talking about Anglos. We want a healthy society.
Yeah.
And you can't separate that. When you're talking about businesses and corporations,
Right.
they want employees that are healthy.
Right.
80% of the people that we are talking about are working, but they're in very low skilled jobs.
Yeah.
And when they get sick, they can't go to work or they can't go to school. So where do they go to? They go to the ER. The reality is that all of us are affected. All of us are impacted. In this city, there's a lot of growth and opportunity. But there are many people who are living in the shadows of that growth and opportunity. And the poverty rate in this city is still around 24%.
Yeah.
And many of them are Hispanic and African Americans. So when you're talking about a labor force, you want a healthy labor force, people who can do their jobs, stay on their jobs, maintain productivity, and everyone benefits. So we're all interconnected.
It's true, though, also, Representative, that the areas where the state population is growing the fastest or changing the most dynamically in this direction. There are often places in the state where we've underinvested in roads and bridges and healthcare and workforce development. If you go down to the valley, the reality is if that's where the population is growing quickly, we've not spent the kinds of dollars on those basic social infrastructure services in the valley that we've spent in other places in the state.
Well, we haven't spent those dollars, period.
Yeah.
I mean, and I'm not just talking about government taking over everything. I'm talking about a public-private
more of an
partnership,
investment.
right, that works.
Yeah.
I mean, if you just look at doctors who are treating Medicaid patients, those doctors are leaving the system. Because they can't make a living. And so now you only have about 1/3 of the Texas doctors that are tending to Medicaid patients.
Right.
So the current infrastructure, the healthcare infrastructure is declining, and the human infrastructure is declining. And we can have the best roads in town, we can have the best water system in town, but if the people who are going to be utilizing those services are not healthy, if they are at home or in an emergency room, then what are we building for? And who are we building for? So whether you look at it from a very fiscal, conservative point of view, to me, it enhances all of our bottom line when we are able to keep our citizens healthy, keep Hispanics healthy, keep African Americans, Asians, Anglos healthy. We all benefit. So the demographics are changing, true. Does that mean that because the city or the county is more Hispanic, that we don't provide health care? And do we think we're going to win by not providing health care?
Right.
The reality is people travel. We're in a very transient society. Okay? So it's in all of our best interests to do what we can to maximize our dollars, not to overtax people, but if people are going to be showing up in the emergency room, then people with private health insurance, they're going to pay the tab. Property owners are going to pay the tab. Right. And I don't think it makes good sense for California and New York, Arkansas, Arizona, to be taking advantage of dollars that we are not utilizing, that we have put into the system, and we're allowing those dollars to go elsewhere because we get caught up on the politics. I don't care what you call it. Right. It doesn't have to be Medicaid expansion. It could be, I think the Texas Hospital Association called it the Texas Way Plan. I don't care what you call it. The reality is we need to come up with something uniquely Texan, to come up with a system that can keep Texans healthy and do it in a cost-efficient manner, and we can utilize the private sector to make that happen.
Representative Turner made the point undeniable that healthcare is healthcare. It doesn't make a difference if it's a Latino population increase or an Anglo population increase, African American population increase. We have to provide healthcare to everybody. But I want to ask you specifically on the question of the economics of providing healthcare to a majority Latino population. And a population, to the Treasurer's point, that may be part documented and part undocumented. There may be particular challenges within that majority population. Do the numbers look different than if we were a population that was growing and it was entirely middle-class Anglo? Like, how does it change?
Oh, so I can just put some numbers to what Representative Turner said. Elena Marks and I have been writing issue briefs related to the rollout of the Affordable Care Act in Texas. And we've been sort of following survey data from quarter to quarter. And our research shows that 40% of Hispanics in Texas are uninsured, whereas amongst whites it's about 11%. So there's a tremendous variation. A lot of that is
right off the bat you have a big difference.
Right. So there's and that's correlated to sort of differences in income between these two groups. But you certainly have a difference according to race. And unfortunately, we don't have a large enough sample to be able to separate out African Americans differently. We could give numbers, and I'm sure that they would be in between those two, but we're not sure how accurate those are. And the other thing is sort of related to the economic returns of providing these people insurance. We worked with Lan Benson several years ago. He came to us in part of the Children's Defense Fund, and he asked us to calculate the economic returns of providing health insurance coverage to children versus the costs. And when we calculated and looked through all the research, it turns out that in the long run, it pays. You get more economic benefits in terms to cover children with health insurance than it actually costs, just because of the improved productivity in terms of the workforce and what these people are able to attribute to the economy over the long run. And I have no doubt that if you actually did that study for adults, you would find the same results. Of course, it's smaller because adults are older than children, but there's several economic studies that show when people get health insurance, they do consume more health care. That's going to cost more, but they also become much more productive. And there's all sorts of direct sort of productivity things, but there's other things. You don't have family members who are sick, so you don't miss work.
Right.
All these other things.
To you and to Ms. Marks, the criticism at the state level, and the treasurer is correct. We've elected folks to the highest offices in the state who have decreed we're not going to negotiate with the federal government on the Affordable Care Act, so we're not going to go there. We want to just basically reclaim our dollars without strings attached. Would it materially make a difference to us from an economic standpoint if we just got some kind of a big bag of money from the federal government with no strings? If we didn't necessarily embrace the system that they're offering to us, but just said basically, give us our money back, could we not solve the problem, this so-called Texas solution, either of you, that way?
You have to structure that solution extremely carefully because governments can shift money from one pot to the other. So, for example,
they do it all the time. We call that a diversion, do we not? Yeah, we call it a diversion.
So for example, we did decide to, the federal government decided to exercise block grants for TANF several years ago for welfare. And as part of that said, look, we don't want you to shift your money, so we're going to implement these minimum requirements that you have to spend 80% of this current amount on welfare payments. You can't shift it somewhere else. I happened to go and look at these data. So these restrictions were set in the 1990s. And I went back and I counted out of these various different states, 50 states, about 10 or 14 states were spending at the levels on welfare that they were spending in the 1990s. And so this is, when you give something that's unstructured, there's an incentive to spend as little as the state wants on the program that the federal government wants them to spend the money on. Then you take the rest of the money and spend it on something else.
Ms. Marks, maybe strings in this case are necessary. Maybe we need strings.
Well, the federal legislators had the guts to tax for this money, and if the state wants to decide what to do with money, perhaps it ought to tax for it. I mean, there is something to be said for if you collect the taxes, then on behalf of those for whom you've collected it, you have the authority to decide what to do.
Yeah.
And so there's a little bit of hubris, I would say, in the state saying, we want low taxes, you go collect taxes, we'll criticize you for collecting taxes, but then just give us the money and we'll do what we want with it.
When you had your city hat on rather than your foundation hat on, did you view this differently?
I would have viewed it differently, but with the same conclusions. I would have viewed it from a public health perspective, and in that sense, everybody here knows that the more people who are insured, the better the health of the community will be. I would also have viewed it from our perspective as a large employer who covered 20-something thousand employees and understood that our health insurance premiums that we paid on behalf of our employees and that they paid when they shared in the premiums was impacted by the rate of uninsured, and so I would have been advocating for programs to increase the number of uninsured. In fact, did so through offices at the city, and in fact, we put in place at the city a pay-or-play program for city contractors that I believe is still in place. And what it does is it acknowledges the fact that when employers don't provide health insurance, if an employee is uninsured and they get health care because they do, that those costs are passed on to taxpayers and to other insured. And so what we did was say the city shouldn't be subsidizing that. If the city is awarding a contract based on a low bid, and the bid is low because the employer or the contractor doesn't include the cost of employee health insurance in their bid, why should the city be subsidizing that? And so we changed the city policy, and contractors had to demonstrate either that they were providing a certain level of health benefits to their employees, or they had to pay a fee into a fund that the city still maintains and uses then essentially to turn around and fund some of the costs of uninsured care at community providers.
We're going to go to questions here in a couple of minutes. Julie will walk a microphone around. Mr. Sanchez, assuming that you got the Texas solution that Representative Turner and others have talked about, where that money could simply come back to us without strings attached, how would you spend it?
Well, first of all, a lot of education in the community. You know, I think Frederick Douglass once said it's easier to build strong children than to repair broken men. And so when you look at our community and you look at the incidence of childhood diabetes, for example, the rates of obesity, these are issues that can be taken care of early on with little intervention by physicians, but let it go unchecked and unabated. You have some serious chronic issues that end up costing all of us in this room a substantial amount of money. So I think that a substantial amount of education, particularly to a community that is often not reached, and you know, I look at the public education system, and for a while there, we had even cut out physical education. Fortunately, we're bringing it back a little bit, but there are a lot of things we can do with respect to hypertension. You just look at the chronic diseases in the Latino community. I'm not a health expert, but I've heard these, and correct me if I'm wrong. But if you could just reduce the incidences of hypertension, which is high in the Latino community, childhood obesity, which eventually leads to diabetes, amputation of limbs, and cardiac arrest and whatnot, you would save millions of dollars in this community. So, you know, we need to get more involved in educating our children with respect to diet and physical education, and not just the children, but the parents. And so I would spend it that way. The other thing I'm concerned about, for example, is if you go to the marketplace to buy, let's just say, two types of insurance, automobile insurance, and you have two DWIs, you're not going to get the same price of auto insurance that I get, that I have a clean record. You're going to pay for those two DWIs because you're a higher risk. With respect to life insurance, if you apply for life insurance, they ask you, do you have questions? Are you a smoker? Do you skydive? Do you ride motorcycles? So forth and so on. So if you're a high risk participant in that pool, you're going to pay a higher premium. We don't do that with health care, and I'm concerned that, for example, under the Affordable Care Act, that all the premiums are the same. We don't step it based on risk. And so I think that education and making people more responsible for their health care is a wise way to spend dollars.
Ms. Ho, you're shaking your head.
Oh, I just wanted to mention that the Affordable Care Act has provisions, with Blue Cross Blue Shield probably knows quite well, that you can charge higher premiums to smokers, and also there are additional provisions. Employers are allowed to give financial incentives to encourage their employees to practice healthy behaviors, and if you don't, you get penalized in your health insurance premium.
And a large part of it is prevention and wellness that's built into it. I think one of the reasons why we're facing some resistance is because not only are there people out in the community that are not informed or educated, but there are policymakers that are not educated. In the legislature, one of the reasons why we face a great deal of resistance is because legislators need education.
How do we do that?
Well, let us pray.
I'm not sure we have enough time left in the hour to solve that problem. I mean, look, the reality, yeah.
I think you can have changes in Austin, Texas, in the legislature. I remember when on the CHIP, Children Health Insurance Program,
right,
we had children had to be enrolled every 6 months. That was keeping thousands of kids from being enrolled.
Yep.
We filed a bill to turn that into an annual enrollment. There were people who said to me and others, you know, they're Republicans, Sylvester's not going to vote for this. They're not going to vote for it. But at the end of the day, educating, sitting down and talking.
Made the case and it happened. Yeah.
64 Democrats and 63 Republicans voted for it.
Yeah.
So inevitably, I think the change is going to occur. I hope it will be sooner rather than later, so we don't lose.
So you're going into what could conceivably be your last session. We don't know. You may have future plans for yourself, but you're going in. Yeah, you're going into a session, Representative, in which if you read the tea leaves and you look at the poll numbers, the likelihood of the legislature being materially different, the makeup of the legislature is going to be almost exactly the same as it is this time. If anything, it may be a click or two a little more conservative. Can you go into the session and tell people here optimistically that you think that anything is going to come out different this time than it did last time in terms of this issue?
And the answer is yes.
Because?
Because we're Texans, and at the end of the day, it's in all Texans' best interest to do the right thing. I think if you state the case, if you try to keep politics at a minimum, talk about the implications of doing the right thing, the fiscal implications of not doing the right thing, and how all Texans can benefit, whether they're Republicans or Democrats. We're all taking care of our families. We want to enhance our bottom line.
Yep.
We don't want to pay high premiums on our health insurance. We don't want to pay high property taxes. And so if you can state the case, keep politics at a minimum, to say it doesn't have to be Obamacare, it doesn't have to be ACA, it can be uniquely Texan. It can be a part of a system where you have managed care, wraparound services, cost sharing, all of things that people like me have been opposed to and not eager, but I'm willing to accept and work with. You know, you got to take the bitter with the sweet. So I think the worst thing that policymakers can do is continue to kill a good thing seeking the perfect, okay? So yeah, I can be optimistic, because I think at the end of the day, we are employees. You all are the employers. And so if we do something, if our job doesn't live up to your standard, you fire us, whether you're Republican, Democrat, or Independent.
Yep.
So yeah, I go back optimistic, because at the end of the day, before I'm a Californian, I'm a Texan. Before I'm a New Yorker, I'm a Texan. Before I'm an Alabama, I'm a Texan. Arizona, I'm a Texan. And we need to do what's in the best interest of Texas and the Houston-Harris County region. And I think if we do that, then Republicans and Democrats can walk side by
Everybody can
side.
come together. All right, let's please put your hands up if you have questions, and Julie's going to walk the microphone around. I see a question. Let's go to that woman right there, and then this gentleman second. Woman there first. Yes.
Thank you for coming today. At the very beginning of the program, you mentioned the rising number of elderly, and along with that will be a drastic rise in the number of people living with Alzheimer's disease. And so that obviously has big health and economic implications. And I was wondering, on a city level, state level, county level, how we should prepare for those individuals and the number of caregivers we're going to need to have to support those individuals.
Let me ask Mr. Murdoch to say a word about that aspect of this if he wants, and then maybe Ms. Ho on the economics.
Well, there's no doubt
aging population.
we will have a large aging population. As I said, we're expected to go from about 13% to about 22% of our total population being people who are 65 years of age or older, and in the absence of something that we do as a miracle cure for Alzheimer's, we will of course have more people who have this particular disease, and obviously it's going to need more attention, I would guess, from both public and private sectors. I'm not an expert on medical things.
Ms. Ho, the economics of that in particular?
I completely agree with that. I keep hoping the folks across the street at the Texas Medical Center are going to come up with a cure for Alzheimer's. John Mendelson's a fellow here at the Baker Institute, and his greatest fear is if we actually are able to cure cancer, everyone's going to be at threat of Alzheimer's degree, and that's actually going to ruin our healthcare budget. It's not as if you sort of cure one disease and provide healthcare. You actually lower costs in the long run, and that's a great fear.
Sir.
Hi, yes, actually, this is a question for Ms. Marks and Ms. Ho. I live at the east end of Houston. In my community, 75% of the children that I work with are undocumented. That means they live in the shadows. And 90% of the people on this planet have never even seen a doctor. So therefore, in my community, if Latinos, there's a good portion of them, they get sick or need health care, they go to the local curandera, they go to the shaman. Those people have the sobadores, they have a giant business there. They don't go to Bentop Hospital. I'm wondering if either of you have looked into that, and instead of figuring out modalities to increase health care for those kinds of people, try to see what we could do in terms of our own healing modalities that are native to my people of Mexico and Texas.
Ms. Marks?
We are very interested at the Episcopal Health Foundation in exactly that kind of work. We are interested in community-based work and in working with different communities and figuring out what works for them. And I would be happy to talk to you afterwards about what that might look like and learn more from you.
You want to jump in on that at all? Anything to add?
Oh, I completely agree with that. You know, I hope in the long run we're moving towards accountable care organizations which give a bundled payment to a large organization for all of the integrated care. And if we could include those types of care within that system because they provide high quality health care and they could potentially lower overall costs. But that's very far out in the future. It's going to take us a while to get there.
Is the question premised, though, that there are an awful lot of people in the state who are not being treated, not because they don't have insurance, but because they just traditionally, as a matter of culture, don't necessarily go to doctors? Is that something that we can try to solve?
Well, you know, a lot of that is, I don't know what percentage, but there is some truth to that. Of course, there's always the fear, if you're undocumented, of going to seek health care
Right.
because you don't know if they're going to document you and turn you in or whatnot. But the fact of the matter is, when I was on the city council of the city of Houston, I remember that we struggled to try to fund federally qualified health clinics in this city. So there, aside from community-based organizations that are in the community, Ripley House and a couple of others throughout the community, there really isn't a whole heck of a lot of access for immigrant communities and a lot of the Latino communities. So I think we need to do better with respect to community-based clinics in our area.
Ms. Marks, do we have an access problem?
We have an access problem, but I think you're thinking from quite a long time ago. We have dozens of community federally qualified health centers in the greater Houston area today, and they are able to and do see undocumented patients, and there are a number of other non-FQHCs that see patients as well. We have an access problem because we've always had an access problem, and as the population grows, the access problem continues to grow. And for lower income populations, that's true. But actually, in the last decade, this community has done a lot to have a lot more access sites for low income, uninsured, including undocumented patients.
Sir.
More on access. This is for Representative Turner. At the beginning of the session, you said that you advocate expanding Medicaid. You also mentioned that only 30% of doctors in Texas see Medicaid patients. How do you propose to provide access to those patients who would be covered by the expansion of Medicare, given that that 30% is not going to change and it's probably going to decrease?
The issue is reimbursement rates for these doctors, right?
One of the reasons why, Dr. Fleming, that number has decreased so much is because the reimbursements are low, what they can get from the private sector. And people are not, I mean, there are a lot of doctors who are performing a lot of care and they're not getting paid for it, okay? But at the same time that there are many doctors that are needing to be paid. So the reimbursement rate is low. Separate and apart from expanding Medicaid, separate and apart from ACA, the number is reducing now under the current system. And it will continue to drop under the current system.
Do you begrudge those doctors the decision, given the way the reimbursements have declined? Do you begrudge them the decision to stop taking patients?
Well, I think people have to take care of their families. We're all in business. I'm in business.
Right.
Okay. And at some point, if I'm not able to take care of my employees, pay for my employees, pay for health care for my own employees, then Barnes and Turner shuts down. Okay. So people are in business, and in business, it's a profit-making business. But they also have to make more than what their expenses are. They can't stay in business. So I don't begrudge them. I begrudge policymakers who put their heads in the sand and turn away $300 million a month so that it can go elsewhere.
Right.
I begrudge them for not doing that. I think doctors are in the business of taking care of their patients, but I think it's nothing wrong for them to expect to be reasonably compensated for the work that they're performing.
Isn't this gentleman's question, though, really get at one of the fundamental issues on this whole debate? People who oppose expansion of Medicaid say that the Medicaid system is broken. One aspect of it that is said to be broken is the relationship between the system and doctors. So if you buy into, in a larger way, a system that's broken, are you not creating a problem en route to solving one?
Well, let me just say this, Evan. When people get sick, Just because there may be fewer doctors attending to Medicaid patients don't mean that they're not going to go to the ER.
Right.
So if they don't go to a doctor, they go to ER. They're going to get treated one way or the other. Now, the question, I'm going back to what was said earlier. I think we have to build out the healthcare infrastructure more. Just like we're building our roads, just like we're preparing for the water system, streets and roads and all of that. The healthcare system we have to provide more access to the healthcare system. And it does require a greater infusion of funds into that system. At the same time, I think we got to do more on the preventive and wellness end. So there are many different angles that we need to approach, but not doing anything and just relying on a system right now that's under a great deal of pressure is not going to solve the problem.
Sir.
This is from Ms. Marks, Mr. Murdoch, Mr. Turner. I'm a publisher and broadcaster, and I have to rely on 24-hour health care at home. My question is the minimum wage going to go up? And B, in January, I understand, I give most of my nurse providers 60-hour weeks. So does that mean in January the federal rule kicks in that they will get time and a half? Because right now they get minimum wage for the 60 hours because babysitters and healthcare providers were the only two under the federal rules that 40 hours did kick in.
You're asking if minimum wage will go up as a matter of federal policy? If there'll be a change in federal policy?
Well, two questions.
Yeah.
One, will Texas take up the minimum wage?
Okay.
Two, the 60-hour piece. Right now, my people are getting paid from Ms. Daltrey's agency today at minimum wage for 60 hours. So will it go up to a time and a half?
Yeah. I don't know what's going to happen on the federal level. I can tell you that that issue will probably be debated in this upcoming legislative session in terms of increasing the minimum wage. The way the law is right now in the state of Texas, even if the city of Houston, for example, wanted to increase the minimum wage, it can't.
Right.
Because statutorily, we prevent even local cities from increasing the minimum wage. I intend to file a bill in this upcoming legislative session to allow cities to make their own determination.
Local control on minimum wage.
That's correct.
Yeah.
And so I intend to do that. Now, when we talk about a minimum wage, we need it.
And that would require a vote of citizens to increase the minimum wage, or would that be a decision just made at a local level?
I think the legislature can make that.
Yeah.
Okay. Now, the other thing is with regards to, we say minimum wage, I say livable wage. Just going back to the providers. My mom, for example, has Alzheimer's, has had it for 10 years. Okay, we have a lot of providers that are coming in. More and more people are wanting to stay at home. They need providers. But many of these providers are maybe making $7, $8. Okay, they need to be paid more. We pay them more. And the reality is it does make a difference. As the population gets older, I think we have to decide whether or not people are going to be going, for example, to nursing institutions or whether or not we can keep them at home. Many people prefer them to be at home. In my own particular example, 5.5 years ago, the doctors put my mom in hospice. We chose to take my mom home, where she's been since 1954. I will tell you 5.5 years later, on August the 12th, my mom turned 90 years old. But the Turner family, we are able to provide my mama with providers 24/7, around the clock. There are two of my sisters who are RANs. Health care makes a difference. Providers make a difference. And the legislature is cutting back, or at least we have been resistant to doing more so that people can keep their loved ones at home. That's why the system in which we're operating right now in the state of Texas, separate and apart from ACA, is not a workable and sustainable one. And whether you're a Democrat or Republican, the bottom line is that you want to take care of your family members, you want to take care of your loved ones, you want a healthcare system that works. We're providing more compensation for doctors to try to bring more doctors into the system to take care of their loans. So there are many different angles that we need to approach. But providers are critically important to the healthcare system in the state of Texas, and they need to be paid more.
Ms. Marks or Mr. Murdoch, I think the question was directed at you as well about the minimum wage. What do you think?
I can't add anything to what the representative has said. Yeah.
Ms. Marks?
Well, if you work full-time and make minimum wage and have a family of 2, you're living below the poverty level in Texas.
Sir, Mr. Jans in the back.
Just wanted to make a quick comment on Representative Turner's comment about education. As one of the people that have been trying very hard to educate folks about Medicaid and coverage expansion, it's not just the lack of education
But as our superintendent out in Katy said, it's not what you don't know, but what you do know that just ain't so. And there's a lot of people in Austin right now that have such a poor understanding of
It's not
what's
just lack of information, it's misinformation?
Misinformation, yes. And there's a repeating of things that are incorrect that causes people to shut down and not be able to hear the economic impact, to not talk about things in an informed kind of way. And so let me just give one quick example, which I think Doug Abel from TMA would, or from the Harris County Medical Society would agree with me on. The number of 33% of doctors who participate in Medicaid is not correct. There's the survey from Texas Medical Association said that there's about 31% of doctors in the state of Texas that accept an unlimited number of Medicaid participants, and there's another third or so of the population that accept a limited number of people on Medicaid. So Medicaid programs like ours, we have 550 OBGYNs. We have 2,000 primary care physicians.
Potentially it's doubled the percentage that was cited
The numbers,
earlier.
if you look at this at HHSC's database, the database is about 60 to 65% of all the doctors in Texas accept some limited Medicaid.
So your question is, how do you combat the misinformation? Is
Yes.
that your point? And I'll let anybody take that.
But I'm going to challenge you on that. If you're saying that 2/3 of doctors in Texas are receptive Medicaid patients, I'm going to challenge you on that one. Because as Vice Chair of the Appropriations Committee, from the last legislative session in 2011 to the one in 2013, the number has been in 2010, that was about 42%. As of 2012, the number went down to about 31%. So maybe we need to look at how we are both evaluating that numbers, but the reality is the number of doctors who are attending to Medicaid patients in the state of Texas is declining because of the low reimbursement rate. That is a reality. That is a fact.
We'll let you all have this out actually afterwards. Let me take one last one, please, before. Well, there are two here. Let's take these two, but as long as they're super quick, okay? Sir, and then ma'am, you'll be the final question.
Much of the conversation today has revolved around unsound public policy. And many of the prescriptions for many of the solutions are quite clear and well documented, and many of them can be effective. Going back to the comment, similar to the comment that was made,
Yes.
Frank Zappa had a great line, "Dare to be stupid." And
He is not often cited at our events, but that's okay.
I think he's the greatest philosopher of the 21st century.
Yes, that's it.
But anyway, that aside, going
Yes.
back to this question of education, in my mind, it's not so much a lack of education, it's the issue of different agendas superseding rational thought. That is a political position that's more rooted in ill-informed philosophy, or people who are trying to be philosophers, political philosophers, rather than legislators solving problems in the state. And
So this is the old politics versus data or science question.
and more to the point, as advocates for a particular healthcare policy, does it make sense to move away from debating the detailed issues and getting people to move from being a debate society to being legislative?
In some ways, this was said about redistricting once, that you take the politics out of redistricting, it's like taking the calories out of fried chicken. I have to believe that taking the politics out of healthcare is probably similarly impossible, right? This is not something that we can really accomplish. Mr. Sanchez.
Well, I mean, you have to have participation levels. I mean, you look at the Latino community, which I try to focus on a little bit because we're talking about changing demographics, but what's the participation rate with respect to Latinos in public policy making decisions? So, one, either they like what's going on in Austin, just decide not to show up to the polls, or, they believe that their voice just doesn't count. So until we have buy-in and a participatory discussion about these important issues, then the status quo will prevail, because everybody that is turning out to vote, not everybody, but a bulk of them, for example, tend to be property owners, taxpayers in the state of Texas, and probably, as I said, because we keep reelecting these people, are perfectly happy with the system at 65 cents per $100,000.
Ma'am, last question.
Representative Turner, there was an article in yesterday's Chronicle on the Outlook page that had to do with dirty air in Houston, which of course leads to all kind of health problems. And it was said that LIRAP, as well as the other one, there's a LIRAP, and what's the other one, Alina?
TERP.
TERP, thank you. Are not fully funded, that those funds that are collected by all of us and heavy truckers just are building up over there. Yes, ma'am. Do you think they should be used for the purpose for which they were intended? Thank you.
They should be used. And basically what she's referring to is that there are a number of funds in the that we have in the appropriation process in which you either pay a fee or a tax, and those dollars are collected from you for a dedicated purpose. In this case, the LIRAP program, which is intended to replace a lot of these old vehicles, there is close to, I want to say there may be $300 or $400 million in a dedicated account intended for that purpose. The legislature, however, will only appropriate a certain amount to the LIRAP program, and the legislature keeps the remaining amount, and it is used to certify the budget.
They're using the money for a purpose other than that which it was intended to.
Imagine that.
That is correct. And so, but it's being used by, but I will tell you, some of the same people who are opposed to expanding Medicaid are the same ones that are holding back the money and are using it for alternative purposes. It is what I call, it's not truth in budgeting, it's not truth in taxation, and it's essentially stealing from a needed purpose and diverting it to another purpose. It is not the legislative process at its best.
Okay, we've come to the end. I want a fascinating discussion, really substantive and great panelists. Let's please thank them. Vivian Ho, Elena Marks, Steve Murdoch, Orlando Sanchez, Sylvester Turner. Thank you to Whitney and everybody here at the Baker Institute, to Julie Montgomery and the Tribune staff, and all of you for coming. Thanks very much.